Hey, good morning, everybody. I'm Matthew Marley. I'm in the Social, Economic, and Housing Statistics Division at the Census Bureau, and I'm very excited to be hosting this session. Like Jason said in the introduction, SIP is near and dear to my heart. I worked on SIP for well over a decade, and I think it's a great data set. And I'm really excited for this conference, that has showcased a lot of the research that people are doing with the SIP, and I think that's just great. So today's session is Immigrants in the Foreign-Born Population. We've got two great papers, and we'll just go in the order of the program. So first, we've got The Impact of State Immigration Enforcement on Immigrant Health by Richard Patty and Courtney Bone from the University of Pennsylvania. And then New Eligibility for Children's Public Health Insurance by Paulette Shaw from the Public Policy Institute of California. And then a couple of Census Bureau discussants will follow that, and then we'll have some time for Q&A at the end. So welcome, and we'll go ahead and get started. First up, we have Richard Patty from the University of Pennsylvania. Richard?
Hi, can everyone hear me okay? I'm going to assume that's a yes. Fantastic. All right, so thank you for giving me the opportunity to present here. This is a work in progress paper that I'm co-authoring with Dr. Courtney Bowen from Penn. We're in the Sociology and Demography graduate group. We are looking at the impact of state immigration enforcement on immigrant health. Trying to skip to the next slide. That's allowing me to do that.
You could click the right arrow on your keyboard. That should make it go to the next. Yep. There you go.
Awesome. So just a little introduction to why this paper is important. So in the midst of kind of this federal immigration policy stagnation in recent decades, state legislatures have really become the primary place of immigrant policymaking, and they're becoming to play a more central role in governing the kind of daily contexts of immigrant lives, both social, political, and economic. Some states have taken a more accommodating stance when it comes to passing these state level immigration policies, things such as allowing state level tuition for immigrants or unauthorized populations, while some have taken more restrictive policies, such as like show me your papers laws or restricting access to Medicaid for certain legal status backgrounds. So these disparate contexts have kind of been linked to disparities in health and healthcare outcomes, which is really what we're hoping to drill at with this paper. Studies have linked accommodating immigrant policies to better health, healthcare utilization. Some of those are obvious, such as access to Medicaid. Some of those, such as allowing access to driver's licenses, allowing people to access certain resources, are a little more indirect, but still have a impact on health and healthcare. On the other side, restrictive policies, these can create a certain environment of fear, increasing stress, increasing anxiety, and have a kind of chilling effect, or the desire to avoid institutional engagement. So these state policy environments are linked to health and healthcare in this way, and these things are entangled with race, ethnicity, and citizenship. And because Latinx immigrants have been primary targets of anti-immigrant legislation and discourse, these state immigration policies are especially consequential for Latinx groups across categories of nativity and legal status. So in the context of the United States, just a little bit more background, the population of foreign-born individuals is growing, obviously. So we have an increase in mixed status households where families have an unauthorized member or a child who has legal status by virtue of their US citizen birth. So we see kind of different dynamics play within households. In general, there's empirical work that shows immigrants experience better health and longer lives in the US foreign counterparts. So this kind of immigrant health advantage pronounced for Latinx immigrants. However, this comes with a caveat. People who immigrate to the United States are those who are more likely to immigrate to the United States. So it kind of selects itself in the sense of people who are younger, people who are healthier are more likely to be able to immigrate. Over time, that advantage disappears. So it appears that this immigrant advantage that people have, the longer that they stay in the United States, this begins to wear away. And work has shown that this is kind of a cumulative effect of exposure to these racialized immigrant incorporation processes. So the health and well-being of non-white immigrants is especially vulnerable. Black and Latinx immigrants are most likely to be racialized as undocumented in ways that pattern health and healthcare utilization at the intersection of legal status, race, and ethnicity. So these different axes of stratification are ways in which we see health outcomes also vary across the population. States have a great deal of autonomy in crafting these policies. While this isn't to say that federal immigration policy doesn't matter, federal immigration policy can sometimes embolden states to enact certain measures. So state policy contexts are really central in governing the daily lives of immigrants and non-immigrant populations in terms of social, economic, political inclusion in ways that shape population health. Federal immigration policy decides who gets in. That is a big part of it. They also decide access to certain programs. But states have the ability to govern once people are within their state or within the country, they are governing the daily context of daily living for immigrants. States also have a large degree of autonomy in deciding who receives access to federal programs such as TANF, WIC, and Medicaid. So criteria for these usage of these commonly used social services are really more determined by states rather than federal policy. So hopefully at this point, we realize that state immigrant policy context is incredibly important when we're trying to understand patterns of immigrant health. Despite increased attention to the role of state policies, we are seeking to address two underutilized areas of research. So first, largely because of data limitations, most studies in this area are relying on cross-sectional data just to look at the link between specific immigrant policies and immigrant health outcomes. We are looking to investigate how changes in state policy across time influence changes in individual and population health, especially among immigrant populations. And second, because few surveys collect data on citizenship or legal status, we also want to drill at this idea of how groups are different based on their immigration status when they immigrate to the United States, and potentially legal status within this. So our two research questions are: how do patterns of health and healthcare utilization vary at the intersection of race, ethnicity, and citizenship? And then how does state immigrant policy context pattern of these disparities in health and healthcare utilization? To the surprise of no one in this room, our data sources is the survey on income and program participation. We make particular usage of the 2004 and 2008 panels, specifically the topical modules of medical expenses, utilization of healthcare, and functional limitations and disability modules. We also link this to data from the Correlates of State Policy project. This is a data set that tracks state-level immigration policy. We utilize years 2004 to 2012, but it extends from 2004 to 2019. For the purpose of our data set, we have 372 state year observations on specific immigrant policies that were passed, whether they were accommodating or restrictive. And this longitudinal data set links quite nicely to the SIPP data, as we're able to link this on state and year measures. For our outcome variables, we are using self-rated health, which it's originally conceptualized as a 5-category ordinal variable, but we collapse it to a binary measure, much as a lot of research in the health field does. One indicating if a person reports fair or poor self-rated health, and then 0 indicating good self-rated health, so if they report a good, very good, or excellent. And this appears in the 2004 and 2008 panels in the corresponding waves. So each row shows which wave they appear in and corresponding to the specific topical module. The next question we ask is trying to get at a measure of mental health. Is this person frequently depressed or anxious? And this appears in the 2004 panel in wave 5 and wave 6. This is the functional limitations and disability questionnaire. And then we also look at how often a person is able to visit a primary care physician in the past 12 months. This is a continuous variable of just it enumerates the number of times that a person has visited a doctor for primary care in the past year. We recode this as a 0 if someone has not visited a doctor in the past 12 months, or 1 if they have done so at all. This is attempting to get at healthcare access. Originally, we had it as the number of times, but we realized that wasn't really getting at what we wanted to see. We're looking for access to care. And if you haven't visited a doctor in the past 12 months, this is indicative of some lack of access. Our explanatory variables are race, ethnicity, and citizenship. So we have 4 categories: white, black, Hispanic, and Asian, and we divide citizenship into the following 3 categories: US-born citizen, foreign-born citizen, and non-citizen. This uses the citizenship question on the SIPP data. If you were coded as a 4, this was a US-born citizen. Anything else, we used birthplace, citizenship, and these 2 measures were used to combine if you were a citizen who was born in the United States, a citizen who was born outside the United States, or did not have citizenship status yet. Another explanatory variable we use are the state-level restrictive immigration policies and state-level accommodating immigration policies by year. So some examples of these accommodating policies as compiled by Reich in the Correlative State Policy Dataset. The unborn child option, so coverage to an unauthorized pregnant woman if legal immigrant children have access to CHIP. Pregnant women have access to Medicaid. They use state funds to cover legal immigrants during their first 5 years of residency, which they are not required to do. Funding to cover undocumented immigrants who are ineligible for federal assistance, driver's license to unauthorized immigrants, and in-state tuition status for undocumented high school graduates or military veterans. And this is not a comprehensive list, but these are just some of the examples of the accommodating policies that are used. Some examples of restrictive policies: use of E-Verify for both public sector and private sector employees, immigration status as a requirement for in-state tuition, show me your papers laws, and no health coverage to immigrants beyond the minimum required by federal law. Not a very high bar to clear. So all of these policies are constructed in this state policy environment that immigrants are living in. And it's important to take this type of legislative environment into account, as all of these things are influencing the context of daily living. We are going to use fixed effects regression models in order to isolate the effect of immigration policy on race, ethnicity, and citizenship. So we lag immigrant policy by 1 year. So the state level immigration policies passed in 2004 are going to affect the year 2005. Those effects are not felt immediately. So that's that subscript ST-1, specific state in time from last year. This REC is this race, ethnicity, and citizenship measure. So we have 12 categories, 4 for race, 3 for citizenship, and we interact that to create essentially 12 cells. The Z is a vector of covariates. Sex, education, and marital status are the covariates in which we use. And then we include fixed effects for the state in an attempt to absorb anything that might be going on in the state influencing health outcomes that is not specifically related to immigrant policy, or race, ethnicity, and citizenship. So maybe a new election within the state, if there was an increase in state minimum wage, things of that nature are going to be captured in that gamma term. For the year fixed effect, we see this is going to get at federal immigration policy, amongst other things. Presidential election would effects of that could be absorbed in that year fixed effect. Any changes to federal immigration policy is going to be absorbed in that fixed effect as well. For instances in which we have the same individual within the same panel multiple times. So for instances when we have self-rated health recorded twice for the same individual in the 2004 panel, we use an individual fixed effect. For our health and anxiety measure, or our anxiety measure, we have a two-way fixed effects model where each individual only appears in each panel once. So that is when we use a two-way fixed effects model, we do not need to absorb that individual fixed effect. Our modeling strategy. So for each, we have three outcomes we're testing: anxiety, self-rated health, and care access as measured as doctor's visits. The first model we use is a baseline model. So that is model 1 for all of them. We just look at the effect of this race, ethnicity, and citizenship, as well as our covariates on each of the outcome measures. The second measure that we use accommodating policies, and there's a typo in care access. We do not have 32 models. We only have 3 sets of models. We're not that ambitious. The second set of models, we look at the interaction between race, ethnicity, citizenship, and accommodating policies. And then the third set of models, we look at race, ethnicity, citizenship, and restrictive policies. And then we see the fixed effects reported for each of these outcomes. Now to look at a couple of descriptives, just based on what we have so far. So this is the distribution of citizenship conditional on race. So we see that the plurality of our Asian component of the sample is classified as a foreign-born citizen. There's not the profiles of citizenship across the bottom. You'll see foreign-born citizen, non-citizen, and US-born citizen. So the farthest bar to the right is US-born citizen. The profiles for Black Americans and white Americans do not differ all that much. For Hispanics, we see that there's a pretty sizable portion of non-citizen and the foreign-born population. And same with a US-born citizen too. Our total sample is 1.7 million cases. The smallest cell that we have is Asian foreign-born citizens, and that has 9,800 cases. So we're not too worried about sample size in either one of these 12 cells. The next slide looks at accommodating policies, or restrictive policies by state. We see over time how state restrictive policies have varied. So in 2005, really the only splash of color we see is Arizona, right around 6 or 7 really restrictive policies. So think of show me your papers laws, restricted access for Medicaid. Anything blue or purple, we're thinking around 0 or 1. So any splash of color we see is a state taking some sort of restrictive action. 2007, we see a couple states, Texas, Arizona, Louisiana, emerging as states that are actively passing restrictive policies. Arizona really emerges in 2010 as we're talking double-digit restrictive immigration policies, as well as 2011. One thing that is a little irritating about this data is that Texas, you'll notice in 2006, 8, 2010, and 2012 has incomplete or missing data. And it would have been really, really interesting to see how they appeared on the state restrictive policy index. This indicates that maybe the data was only released every other year. But we see the usual suspects, as well as in 2008, South Carolina has 15 restrictive immigration policies. So that was a bit of a surprise, but that is just looking at the variation that we see in restrictive immigration policies by state. We should expect to see some sort of effect for immigrant populations living based on state. Next slide we see is accommodating policies by state. So again, 2005 and 2006, not a lot of action going on here. In 2007, California steps onto the scene as a place where a lot of accommodating policies are passed. So this is a driver's license for unauthorized immigrants, in-state tuition status, legal immigrant children have access to CHIP, all of these things. In 2009 and 2010, California is still consistently passing a large amount of accommodating immigration policies. 2012, California, as well as Chicago and Philadelphia, Illinois and Pennsylvania, are also passing a large number of accommodating immigration policies. There is a little bit more variation in the restrictive policies, but as the scales are largely the same. But we see there definitely is a longitudinal difference in accommodating policies by state. So the cross-sectional view, while valuable, a longitudinal analysis is, we think, is fairly important. This is the distribution of our outcomes by our race, ethnicity, and citizenship measures. As we see for anxiety, there's not a ton of variation based on, I'm going to say REC measures just for brevity. Not a very large distribution of REC measures conditional on our rate REC measures. As we look across all rows, there's really not a ton of variation that we're going to see in this specific outcome. So it will be interesting to see when we introduce policy measures into the mix, does this interaction cause any type of variation? The next slide we have is looking at self-rated health. And again, not a lot of variation. We see that for Black US-born citizens, unfortunately and predictably, they have the highest likelihood of reporting poor self-rated health in the group. Hispanic foreign-born citizens are also fairly high as well. There's a little more variation here when compared to anxiety measure, but you'll see that most of the bar graphs look pretty similar. So again, the variation on this outcome is not a ton. And again, 1.7 million cases. Our lowest cell is 9,800. So we're looking at a decent enough sample size within each of these. Where we begin to see variation is looking at our access to care. So as opposed to the patterns that we see for anxiety, as opposed to the patterns we see for self-rated health, we see that there is a great deal of variation here based on REC category. The reference group that we're going to have in our models is the white US-born citizen down in the bottom right. And we see that 4 out of 5 white US-born citizens report having this access to care in the past year. Hispanic non-citizens, the majority did not. The majority did not have a primary care visit in the past year. For Black non-citizens, second row, first column, we see that 2 out of 5 do not have access to care in the past year, or do not have a primary care visit in the past year, as well as same for Asian non-citizens, row 1, column 2. Also 2 out of 5. Asian US-born citizens, also a fairly high percentage, are not, about 1/3 do not have a primary care visit in the past year. And white non-citizens as well. So there appears to be, if we look at all of the non-citizen categories, there appears to be some sort of axis of citizenship in which these measures are divided by. So while we have our individual health outcomes, it is in this healthcare axis proxy that we begin to see the variation on these axes of citizenship especially, but also race. The next thing we have is just preliminary models. So we have yet to incorporate our policy measures. Again, this is a work in progress, but this is the baseline measure for each of our outcomes. So our baseline models include our 12 categories of race, ethnicity, and citizenship, as well as our covariates of sex, education, marital status, and age. So with our reference group is white US-born citizens. These are fixed effects. These are linear probability models. So all of our variables are on a scale of 0 to 1. They're binary measures, but we run them as generalized linear model, not with a logistic regression distribution, but rather as just a linear model varying 0 to 1. So these coefficients can be reported as the difference in probabilities of certain things compared to white US citizens. So for example, Asian foreign-born citizens, the probability of reporting poor self-rated health is about 1% less than white US-born citizens. If we look at our self-rated health column, there's not a ton of variation that we see. In our anxiety column, so the probability of reporting anxiety, all of the groups that have a significant coefficient among Asians and Black Americans in our sample, they actually have a lower likelihood of anxiety, regardless of race or foreign-born status, than white US-born citizens. The variation, again, comes from doctor's visits, so access to health primary care physician in the past year. For the Asian foreign-born population, Asian non-citizens, and Asian US-born citizens, Asian non-citizens are 16% less likely to have access to primary care in the past year. And we see the same thing for Black non-citizens, almost 11% less likely to have access to care in the past year. And while this isn't, this is a fairly large number, but we have to also think of our sample size, and this is a lot of people that are being impacted by just access to care on race, ethnicity, and citizenship. The next panel is going to show Hispanic and the other two categories of white Americans, not our reference group. So for Hispanic foreign-born citizens, we see that the likelihood of having a doctor's visit is almost 10% less likely than white US-born citizens. There's not a ton of variation in self-rated health, but for anxiety, we see our first positive coefficient. Hispanic US-born citizens are more likely to report experiencing depression or having symptoms of depression or anxiety than our reference group. That's the only positive coefficient in the anxiety models. And Hispanic foreign-born citizen as well. So that is interesting in and of itself. The fact that Hispanic non-citizen has a lower likelihood of anxiety, albeit a very, very small negative effect in terms of the magnitude of the coefficient. This is an interesting finding based on what we would expect from immigration policy, and specifically who that targets, being Hispanic non-citizens. For access to care, the largest negative coefficient, unsurprisingly, was Hispanic non-citizens, 25% less likely to access care in the past year when compared to our reference group. Hispanic foreign-born citizens and even Hispanic US-born citizens less likely to access care, and white non-citizens. So this access of citizenship, their only differentiating factor is their citizenship, 10% less likely to experience access to care in the past year. So again, these are just preliminary results looking at our REC measure. Once we incorporate our policy measures and our policy measure interactions, we're hoping to see really isolate the effect of what policy can do, both accommodating and restrictive. So as I discussed, REC variation in doctor visits was what we see in our preliminary models the most. Hispanics, both foreign-born and US-born, have a higher likelihood of anxiety than our reference group, only positive effects that we see in the model. And there's really not a ton of variation in our self-rated health outcome. And we're looking to see if what state-level immigration policy does. So the next steps, we need to find the best operationalization of our policy measures. So from 2000, we remember our policy maps, there was a lot of blue and a lot of purple. What is the best way to conceptualize that measure? Is this going to be a continuous measure? Are we going to create a categorical variable of 0 policies passed in the past year, 1 to 4 or 5 or more, or something of that nature? And then we need to introduce our policy measures to the model, interacting with race, ethnicity, and citizenship. That is all that I have. I thank you for your time, and I look forward to hearing your feedback, because again, this is a work in progress, and again, just thank you. I look forward to hearing what you all have to say about it.
Thank you, Richard. All right, so next we have Paulette Shaw, who will talk about new eligibility for children's public health insurance and the effects of family nativity. So Paulette, I can either advance the slides for you, or you can request control like Richard did and advance the slides yourself.
Hi, I think I can try to control it. You said it's just the right arrow, right?
You do have to request control from me first.
Oh, okay. Yeah, I'd like to request control. Is there a button I should press, or is it just?
Yeah, you have to do something in your settings to request control, and then I can enable it on my end after you request it.
Okay. Do you know where that's located?
At the very top right, underneath the clock, there looks like a little computer monitor. I think, I'm not sure what the logo is, but it's an Ask to Control icon.
Oh, thank you. I was not looking anywhere near that.
I struggled to find it for a while. That's the only reason I know.
That's great. Thank you. Okay. I think I'm taking control. All right. I've taken control. Great. Okay. Thanks so much. I guess this is great. I'm really excited to be a part of this session. Thanks so much for organizing and for inviting me to participate. My name is Paulette Shaw, and I am presenting a paper from my grad thesis investigating children's differential take-up effects of public health insurance by family nativity. I think I can just do this. Okay, good. Whoops. All right, sorry about that. During my study period, 96 to 2013, many children became eligible for public health insurance through Medicaid expansions and through the introduction of the Children's Health Insurance Program, also known as CHIP. I have a couple of research questions in this project. First, how do these policy changes affect health insurance status, so coverage specifically among low-income children of U.S.-born parents, or Native parents, as I sometimes say? And also, are there differences by family nativity or immigration status? Is there evidence of a chilling effect? And I'm just going to preview my preliminary results. Forgot to say preliminary. But for low-income children with native-born parents, I estimate a 7.3 percentage point increase in public insurance coverage attributable to policy changes. And for low-income children with at least one documented immigrant parent, but no known undocumented parent, I find no take-up effect. And finally, I estimate about an almost 11 percentage point increase among children with at least one undocumented parent. So these are kids in undocumented or mixed status families. Overall, having an immigrant family depresses take-up of public health insurance as some of the most disadvantaged children, those with undocumented family members, do enroll. So a little bit of background and motivation. So there are many reasons why we may believe that children in immigrant families, whether immigrants themselves or children of immigrants, may be an especially vulnerable group with respect to health, even among the larger group of low-income children. So some sources of immigrant health vulnerability include low socioeconomic status, legal immigration status, as well as language barriers and other cultural concerns. Immigrants are also less likely to have health insurance through employment than natives. And based on their economic characteristics, newly eligible children in immigrant families may be expected to take up public health insurance at greater rates than those in native families. But these other barriers, legal status, language, and others, can work against this. So there have been some studies in the past. There are kind of a range of findings. I would say that some past work on children of immigrants have found that this group is similarly responsive to public health insurance expansions as children of natives. However, a more recent study has found that children of immigrants have higher take-up of public health insurance and also higher utilization once insured than children in Native families. A little bit more background. So going back to legal status concerns, the undocumented are especially disadvantaged in many ways. Most undocumented immigrants and their families do not participate in Medicaid, and more recently they are excluded from most provisions of the ACA. And about the potential chilling effect that I mentioned earlier, and was also mentioned in the earlier presentation, it's not only the undocumented who may be affected by a chilling effect, but also their family members who may decline to participate in programs they're eligible for. So increases in immigration enforcement have been shown to chill participation in Medicaid, even by citizen children of immigrants, and to increase food security in Latino immigrant families and children, and increases in deportations reduce WIC participation among mixed status families. And that's especially interesting given that WIC is one of very few safety net programs that does not screen on legal status. And a more recent note is that adults in mixed status families reflect less woodwork effect due to the ACA Medicaid expansion. This is a snapshot from 1996, the start of my study period, and this is state variation in Medicaid eligibility, income eligibility for children. So as many of you know, Medicaid used to be linked to AFDC cash assistance, but a series of expansions, notably in the 80s, began to loosen that connection. And then as well, there was a big federal Medicaid expansion in the early 90s that mandated states to cover children under age 5 up to 133% of federal poverty, and older children up to 100% of federal poverty. But this only applied to cohorts of children born after October '83. So every year another age was included in the expansion until age 18. And then, of course, right before my study period began, the AFDC Medicaid link was broken with Clinton welfare reform, and Medicaid became a program serving low-income children and certain groups of adults, such as the disabled, and Medicaid no longer had a family structure requirement. So here is just a snapshot of just a few states and where they were at in terms of income eligibility thresholds for children by age in 1996. In addition to Medicaid expansions happening over the study period, there was also the introduction of the Children's Health Insurance Program. It's called CHIP, and I think it used to be called SCHIP, with S standing for state. And it is a program designed to cover moderate income children whose families were too high income to qualify for Medicaid, but were still unable to afford insurance. Let's see, the implementation dates and program design did differ by state. Some programs could be a Medicaid expansion, they could be a separate program or a blend. And some states took the opportunity to combine the last phase of that Medicaid expansion by age with CHIP as Medicaid expansion. And then at the time of implementation of CHIP, income thresholds ranged from 100 to 300% of federal poverty. And as with Medicaid, I would say that for CHIP, there was a tendency for states to implement more generous income thresholds over time. In addition to the public health insurance expansions, there are, I would say, other types of state variation in terms of programs and resources for immigrants. I feel like this is kind of reflective of the previous presentation as well. So Clinton welfare reform not only changed cash welfare and its relationship to Medicaid, but it also greatly reduced immigrant eligibility for public programs, and that was also true for documented immigrants. So the conversation moved from one of documented versus undocumented to one of qualified versus not qualified, and most immigrants and most documented immigrants did lose eligibility for public programs, including specifically Medicaid. So there was a 5-year, I'm going to call it a 5-year bar, I think it was called, on legal permanent residents participating in Medicaid. But some states did get around this by covering documented immigrants with state funds. And by the end of the study period, a handful of states also offered children's public health insurance without regard to legal status. This isn't exactly study relevant, just a little bit of extra context. There are some health resources that immigrants may make disproportionate use of due to barriers to care or lack of insurance coverage and therefore an inability to pay. And those include community clinics, emergency rooms, as well as transnational health. I'm going to move now to the study. So the data, unsurprisingly, I used the SIPP. I'm using the 96, the 2001, the 2004, and 2008 panels, and the resulting study period is 1996 to 2003. I focus on about 641,000 observations of about 79,000 unique children. The study children are all observed to be low income with at least once in the SIPP. And by that I mean that they have a family income of at most 250% of federal poverty. And of course, the SIPP's second wave includes a topical module on migration history. So using topical module data on place of birth, U.S. citizenship, and naturalization, as well as permanent residency status, I identify whether study children have family members, typically parents, who are immigrants. And I define immigrants as foreign-born, but not to U.S. citizens abroad. And a subset of these children with parents who are likely to be undocumented. And it's a bit of a proxy, but I define that as adults who are immigrants, but never adjusted to permanent residency or citizenship. So these are not perfect proxies, but they're closer than what's available in most other surveys. So I just want to note that I don't get into the immigration status of study children themselves. Of course, the survey respondents in the topical module have to be at least 15 years of age, and the preponderance of children of immigrants are U.S. citizens. So I actually just kind of leave out the question of what are the children's immigration status. And then just to note that the study includes only the 4th reference month of each survey wave to address concerns about student bias. So of course, the most intuitive approach to estimating take-up due to eligibility changes would be to model take-up against eligibility. But eligibility for public insurance programs such as Medicaid is essentially a proxy for poverty. And poverty, of course, introduces a whole host of confounding factors, and being poor is far from being randomly assigned. To address this concern, I use an established empirical approach, which is to instrument for eligibility using a variable called simulated eligibility, which is a parameterization of policy changes that is, I'm going to say it's purged of individual characteristics. It's really just about the policy changes over state, time, and child age. To create simulated eligibility, I randomly select 300 nationally representative children of each age from 0 to 18, but actually I think it might be 0 to 17. I don't think I called 18-year-old children at the beginning of the study period. And then I take only their age and family income as a percent of FPL. And then I calculate their eligibility in each state time scenario of the study period. And then for each of those scenario level cells, I take the average eligibility for each age. And so that cell level eligibility is simulated eligibility. So I'll turn to the model in a moment, but I did want to mention that it does contain interaction terms for having an immigrant parent and an undocumented immigrant parent using those, the definitions of immigrant and undocumented that I mentioned previously. And then this is just a couple of trends to show what simulated eligibility and actual eligibility look like in the data. So this is for the study children over the analysis period, and the trends are similar, although simulated eligibility tends to be higher in general. The outcomes of my study, of course, public insurance, that seems pretty clear. I look at public insurance coverage only and also in combination with other coverage. And I also look at related insurance outcomes, private insurance and uninsurance. The specific outcomes are has any public health insurance, has public insurance, but does not have private insurance, so doesn't have a combination of the two. Private insurance is always just true if a child has private coverage, and then uninsurance is essentially the residual. Uninsurance is one if a child has neither public nor private coverage, and all of these variables are binary. Okay. So as promised, back to the model. So you can see those indicators for immigrant family and undocumented family I mentioned earlier. This regression is operationalized as a two-stage least squares linear probability model. ELIGE-HAT is instrumented eligibility using simulated eligibility as the IV. And the control variables I include are age and its square, race and ethnicity dummies, state by year unemployment, as well as fixed effects for state, calendar year, and SIPP panel. And I calculate robust clustered standard errors at the state level. And then I'm going to present and interpret estimates for beta 1, which is the take-up effect for children with U.S.-born parents or Native families, as I say, as well as beta 1 plus beta 2, the take-up effect for children with at least one documented immigrant parent and no known undocumented parents. So I'm going to call these kids in documented families. And beta 1 plus beta 2 plus beta 3, the effect for children with at least one undocumented parent, and I'm calling these families undocumented or mixed status. Okay, so this slide shows characteristics of all the study observations, and so that includes the repeats of children who are followed over time, but kind of surprisingly, aside from age, the characteristics don't change much if we focus on just the unique children, so I'll just use this as one of as a reasonable representation of the children in the study. So about 38% are enrolled in public insurance during the study period, and close to 49% have private insurance, and about 18% have no health insurance. In terms of demographics, about 23% have immigrant parents, and that includes documented and undocumented, and about 5% have undocumented, at least one undocumented parent, so they're from an undocumented or mixed status family. The sample is about half male, a quarter Latino, and over 70% white, and about 20% of the remaining being all other races, including Asian and Native American. Eligibility for public health insurance is about 66%, and as we saw earlier, simulated eligibility is a little bit higher, it's around 82%. So here are the main findings for having any public health insurance, typically Medicaid or CHIP. So first I'll point out that the first stage of stat is over 900, so that does give us some confidence in using the simulated eligibility instrumental variable. Children in Native families have a 7.3 percentage point increase in Medicaid or CHIP following new eligibility. That's about a 19% increase over this group's mean public coverage. And children in documented families did not have a take-up effect. The point estimate is positive, and I can't rule out the possibility that sample size was an issue, and perhaps having more children in the group would have produced a more precise positive take-up. And finally, children in undocumented or mixed status families had almost an 11 percentage point increase in Medicaid or CHIP. And this, for this group, that's about a 22% increase above their mean public health insurance. This is now a set of findings, public health insurance only, so no dual coverage, private health insurance and uninsurance. So for each group of children, this set of estimates should sum to 1, since they're all mutually exclusive and cover all insurance possibilities. Having said that, I think next time I would present the table differently and cluster the results by family type instead of by outcome variable, just to illustrate that a little bit more clearly. So for children in U.S.-born families, they still have a 5 percentage point increase in public coverage take-up, but the smaller estimate's only marginally significant. There's some evidence of crowd out in the form of a negative point estimate for private coverage, but this estimate is not significant. And finally, this group's uninsurance estimate suggests that improved coverage overall did occur, but again, this estimate is not significant. So for children in documented immigrant families, we still have a positive public coverage estimate combined with negative private coverage and positive uninsurance estimates. This too suggests crowd out occurred. However, all estimates for this group are not distinguishable from zero. Finally, the most precise estimates are for children in undocumented mixed status families. They have almost a 10 percentage point increase in public coverage, so this is public coverage only, and a substantial crowd out of 20 percentage points, and I would say a puzzling 10 percentage point increase in uninsurance. So children in U.S. born and immigrant families had positive public insurance take-up following new eligibility, but there was no clear gradient by family type. And what I mean by that is I might have expected that there would be a growth or a decrease for immigrant family children, and then a further growth or decrease for children in undocumented or mixed status families, but that was not the case. Instead, children in undocumented or mixed status families were most responsive to policy changes. There was likely crowd out in all three groups of children, although estimates were not all precise enough to be able to say that with confidence. The crowd out magnitude, if taking the point estimates at face value, it's especially large for children in documented immigrant families. Let's see, some key limitations of the project. So of course, measurement error is always going to be an issue in studies of undocumented individuals. Further, some undocumented immigrants may have chosen not to participate in the SIPP survey at all due to not wanting to engage with government entities such as the Census Bureau. And then the study uses data ending in 2013. So of course, all of this is pre-ACA Medicaid expansion, although it does capture sort of the very beginning of what are called the early expansions, but it's not the full Medicaid expansion. And then finally, up to this point in the study, I don't take advantage of this longitudinal design. So the conclusion for now is that having an immigrant parent depresses responsiveness to new eligibility for public insurance overall, but children in undocumented families do manage to enroll. All of this work treats observations in the SIPP as repeated cross-sections. So one idea is to conduct an individual fixed effects model. Some drawbacks about this idea would be that I'd have to remove children who appear in only one wave, of course. And then I would also have to drop interstate movers to be able to cluster standard errors by state. So I think that would change the sample in some significant ways, and I'm not sure if it would be the right next step. So I guess I look forward to hearing feedback and ideas from my respondent. And thank you, Catherine Starkey, for reading my paper. If anyone would like to follow up with me after this conference, my contact information is here on the slide.
All right, thank you, Paulette. So two really good papers. And next we have two discussants from the Census Bureau, each of whom will address one of the two papers. So first up, we have Virginia Jenkins, who will discuss the first paper. Virginia?
Hi there. Can everybody hear me and see me? There we go.
Yeah.
Okay, great. So thanks, Richard, for sending me this paper and letting me read it and discuss it. I really enjoyed it. While this isn't really my topic of study in the past, it was super interesting to dive into. And my name is Virginia Jenkins. I'm with the Population Division of the U.S. Census Bureau. So I wanted to start out with just kind of an overview of the key contributions that I think this paper really adds. So as you all heard, it really explores how immigration policy influences differences in health disparities by race, ethnicity, and legal status. So one of the main important things here is that it uses longitudinal rather than cross-sectional data. As they mentioned, a lot of the data in the past has had limitations, and so longitudinal analysis was not achievable. So this paper really adds that in a novel way. And so they're using that longitudinal data. They're really trying to see how changes in state policy, either more accommodating or more restrictive, affect the health of people across time, across the axes of race, ethnicity, and citizenship, both at the individual level and population level. So aside from the longitudinal data strength here, there's a couple other strengths that I really like about this paper. So there's also, they have this race, ethnicity, nativity, citizenship measure that I really think offers a dynamic evaluation of the cross-section of these three important and independent axes. And when I say nativity, that's kind of the citizenship measure that I'm referring to, where they distinguish between US born and foreign born. So with this measure, they make these three distinct groups for every racial ethnic category, including foreign-born citizen, non-citizen, and US-born citizen. So another thing that I really like about this paper is that they use multiple measures to assess health and healthcare utilization. So as they mentioned, they tried to capture a mental health measure using that symptoms of anxiety or depression measure. They also use self-rated health and the number of provider visits. I guess they changed it to whether or not somebody had accessed preventative care in the past 12 months. So that's seems pretty robust and covering a lot of bases there. So one thing that I would really like to see in this paper, and maybe I have several discussion questions that we can all discuss as a group here. But something I would really like to see in this paper is more of a discussion, perhaps in the background, on why communities of color and non-citizens may not be accessing healthcare. There's a myriad of reasons that this could be. Like, and it's probably all a combination of all of these, but a discussion would be helpful. So is it because of stigma in the healthcare setting causing these groups to avoid accessing healthcare? Is it an inability to get time off work to visit a doctor because these groups tend to have blue collar or less flexible jobs? Or is it because of a lack of insurance or funds to pay for healthcare? I think these are all important questions to address moving forward. So as I mentioned, I'd really like to frame this discussant role as a discussion between all of us as a group here, including the authors. So I'd like to start out with this first discussion question, which might be better answered by you, Richard, but I'm sure other people will chime in as well, which will be great. So I really wondered whether or not immigrant concentration played a role in health. This is just coming from the perspective that social support has really been shown to play an important role in health, with those with better social support networks reporting better health. So it would be really interesting to evaluate here if states with higher immigrant populations have better outcomes despite restrictive policies. So I don't know if we want to pause there and have a short discussion before we move on to my other discussion questions here.
Why don't you go through your questions, and then we'll do the second discussion, and then we'll give the authors a chance to respond, and then we'll open it up to everybody.
Okay, that works. Sounds great. So that first one is about immigrant concentration. And then I know that this is always the main problem with any research. And we all wish that it were not, but I'd be really interested in looking at other mediating factors that might influence the relationship between policy and health. And I know that you guys haven't run the analyses yet to really see how policy is influencing health directly. But I think it's really important to conceptualize other potential factors that could be influencing this relationship to the extent that you can. We all know that data doesn't give us everything that we would like to have. So mediating factors, and then also another question here is I know you guys have some descriptive statistics about how US born versus foreign born are faring across these outcomes. So I would also really like some information here, maybe in the multivariate analysis, this will be answered. But I'd really like to know how race and ethnicity and nativity is affected by immigration policy if they are citizens. So I know you talked about how Latinx groups and Black groups are most likely to be racialized as undocumented, but I'd really like to see this come out in the data. So how are these groups who are not non-citizens or who are citizens being affected by these immigration policies? Next, you brought up some interesting points about mixed status family and their prevalence in the US here. But then I didn't really hear anything else about that, especially in the analysis. So this might be an important future direction. It's probably out of the scope of this paper. But it'd really be interesting to have some analysis of mixed status families. So are people who may not necessarily be undocumented, but are in a mixed family where their family members may be undocumented, is their health affected by these restrictive or accommodating immigration policies? So that's an important future step here. And then another one, which is probably more leaning towards a data limitation problem, but my brain goes to thinking about the intersectionality of multiple races specifically. So if somebody is reporting multiple like people of color groups in like multiple races in their own identity, is this creating an additive effect, creating even worse health for them, or is it negating that effect? I don't know. That would also be a interesting follow-up for this study. So those are all my discussion questions here that I'd like us all to think about. And again, thank you for having me on here. And thank you, Richard. I really enjoyed reading your paper and learning a little about this topic, and hearing you present. I really like what you've added so far. So I can't wait to read more of it. Thank you, everybody.
Thank you for reading it.
Of course.
Thank you, Virginia. So next we have Catherine Kiesler-Starkey from the Social, Economic, and Housing Statistics Division, who will discuss the second. Catherine?
Okay, I'm going to take control here. Okay, great. So I got to read Paulette's paper, New Eligibility for Children's Public Health Insurance, the Effects of Family Nativity. And I really enjoyed this paper, and I'm so glad that we have Paulette here. I know it's really early for California, but I'm so pleased that you joined us at this conference because this is a really fantastic paper to read. Is it sort of, okay, there we go. So a little bit of background, you know, I'm in the Health and Disability Statistics branch, and so we just think that looking at children's health insurance is so important. And children of immigrants should be focused on specifically because there's been increasing eligibility for CHIP over time for all families, and there's been a lot of research on how those increases have been really beneficial for children. But immigrant families may be more reluctant to interact with government, and therefore efforts to increase health insurance for children may work a little bit different for this group, which Paulette refers to as the chilling effect. So, you know, what can we say about health insurance access for this specific group of kids? And the answer in the literature is it's difficult to say because there are these conflicting outcomes. There's some previous papers from Bachmuller and Curry. They find that children of immigrants are no more responsive to new eligibility, but a more recent paper from Branchetti finds that there are higher take-ups for children in immigrant families. So there's still this outstanding question in the literature. And something that's really important to point out is that in Paulette's paper, she's able to take this a little bit further because she's not just looking at the difference between children of immigrants and children of Native parents. She's actually able to also separate out children of documented immigrants and children of undocumented immigrants. So that's a really important extension into the literature that we get from her paper. So since it's the SIPP conference, I thought I would point out why SIPP is so important for this paper. There's shorter recall periods for the data in this analysis. It's triannual waves, so only 4 months of recall. And this paper from CARD shows that SIPP might be a little bit better than other surveys with public health insurance reporting. And because there's really good data on immigration, healthcare utilization, those are our independent and dependent variables of interest. And because there is really highly detailed sociodemographic information, Paulette was able to use information on state Medicaid and SIPP eligibility laws, which must have been a pretty heavy lift to collect. So nice work on that. And then information collected by the survey on things like family poverty level. And she can then proxy who is eligible and who is not. And furthermore, she pointed out that she's able to create a proxy for undocumented status, which again, pushes a little bit further in the literature because many other surveys aren't able to create quite as convincing of a proxy for which parents might be documented versus undocumented. So this study, as Paulette points out, we can't necessarily look directly at eligibility because it's so correlated with poverty, which might be correlated with a lot of things that fall into that error term of the second equation. So there's instead going to be a two-stage least squares. This is very similar to what was used in the Curry and Gruber Saving Babies paper. And it's also very similar to that Branchetti paper, the one that I mentioned found a stronger response from immigrant families on public insurance take-up. And it's more similar to the Branchetti paper in the sense that rather than just a completely random sample of children, the simulated eligibility variable in the first equation chooses a sample of children stratified by age. And I presume the reason for doing that is so that you get a good selection of children of each age group, because as it was shown in Paulette's presentation, some eligibility requirements are based on age. There's different requirements for infants, children under age 5, and children 6 and over. So it takes these hypothetical children and says, in a given state year, would they be eligible? And then the proportion eligible becomes the simulated eligibility variable in the first equation. So that really nicely gets around that issue with endogeneity that we might see with a straight eligibility variable. So, you know, the highlights are that we show that native public insurance, children of native-born parents, their public insurance goes up. Undocumented immigrant children, their insurance goes up. There's an increase for the children of documented immigrants, but it's not statistically significant. So in the world of that question between the Bachmiller and Curry paper versus the Branchetti paper, this comes out on the side that there's really no real difference between the native, the children of native-born parents and the children of immigrant-born parents, especially, you know, once you combine those two groups of documented immigrants and undocumented immigrants. And I think that is mentioned in the paper in the conclusion. That's really like, you know, hit on that this follows the results of you know, the earlier work, not the more recent work from Branchetti, but I think that could also be hit on somewhere in sort of the actual data analysis, just really point out where this stands in the literature, and maybe even do a direct test of that increase that we see in the children of native-born parents and the increases we see for the other groups to actually test for significant differences. And then next, Paulette looks at public, private, and uninsured to see if there's private insurance crowd out. That is, are these increases in public insurance pulling people out of, you know, private insurance that they were already using. And there's not really a lot of statistically significant changes for the children of native-born parents and documented immigrant parents, but for undocumented immigrants, there is this little bit of a puzzle where we see a really large decrease in private insurance, such that we actually see an increase in the uninsured rate. So I looked back at the Branchetti paper where a lot of this model was based on. And there were a few things that I thought you could do from that paper that could be sensitivity tests to maybe sort of look at that puzzle and maybe try to work through it, because I do think that that was the biggest thing that jumped out at me in the paper of why is this happening? And so one thing is that Bronchetti ran a separate regression for children and families with incomes below 400% of the federal poverty level. So I'd be interested to see if that has a similar result, that could strengthen your argument, or if it says something different, you could dig into why that might be. It also seemed as though Bronchetti ran this IV separately for immigrant families and native-born families. So I do think that that's like one slight difference in the way these models were run, and I'm interested in if that affects this significantly, and I think that that'd be a really interesting sensitivity test to see what's going on here. And in your presentation, you said that the simulated eligibility was based on the age, state, year, but in the formula I saw in your paper, it just said simulated eligibility based on the state year bin. So I think that maybe the formula needs to be corrected. Just look at that model, because I was wondering if it should be age, state, year bins for that first stage. And so a couple of additional thoughts. So maybe this is a problem that doesn't exist for the people who attend this conference, but I don't usually work with the SIPP. So you did mention very briefly in your message section that many children are going to appear in the model multiple times because it's a longitudinal survey. And I wasn't sure exactly what that meant. I assume that it's corrected by using specific weights that are available in the SIPP. But if that's the case, if you could just add a little information on that, just to make people like me who are a little bit less familiar with these longitudinal surveys feel more comfortable with the fact that this equation, this model is going to have the same child appear multiple times. And then, as you mentioned, a lot of change in the political landscape. The Affordable Care Act went into effect in 2014. And also, on the other side of the equation, the Deferred Action for Childhood Arrivals has also gone into effect since that time. So the chilling effect that you talked about might be a little bit different now that that relationship between, an undocumented immigrant parent might be different with the government now, especially if that undocumented parent was a childhood arrival. And also, as you mentioned, in 2013, 3 states and DC expanded CHIP to undocumented families. So, all those things are really interesting. I know that you say that you had to cut off this study in 2013 due to some changes in the way the variables were constructed in CHIP, but I do think it would be really interesting if there's any way you could push this forward in time, even just a little bit, to see how these changes in the political landscape might have changed some of these effects. And so just overall, this is an area of the literature where I think it's so important to study because of those conflicting conclusions. And I think this paper does a really nice job of addressing those. And, this is just such an important topic for me personally. I really care about it. And I think that it's fantastic that you're looking into this. And it really shows how the richness of SIPP data is so important. So thank you so much, Paulette. This was a great paper to read.
Thank you, Catherine, for reading my paper and for giving me such concrete ideas for next steps and for improving the work that's already been done, as well as building on kind of some of the questions that I have about where to go next. So this is really great.
All right. So before we open it to the Q&A, let's have the authors give any responses that they have to the discussants. I guess we'll go in order. Richard, do you want to go first?
Sure. Yeah, Virginia, I really appreciate the kind words about the initial version of this paper, as well as some of the things that could help potentially improve it going forward. Yeah, on the front end, I think that we are going to really delve more deeply into why communities of color non-citizens have trouble accessing care I think that's an important piece of the puzzle to kind of set the stage for our analysis. I do think that we have the ability to look at, well, we do have the ability to look at social support networks influencing health. There's a interesting empirical literature on especially how mixed status families, how they pool resources together in an effort to, or even on in undocumented families too, how they pool resources together in an effort to make sure that members of their family receive care, so they know certain doctors to go to. Sometimes they share medications, things of that nature. So social support is a big factor. We have state level immigrant population by year. Part of the reason we didn't include that is we weren't sure how much of a social network state level immigrant population is, but definitely at finer grain data, if we were able to have like access to county level data, that might be a very, very interesting variable to explore going forward. In terms of groups who are non-citizens affected by immigrant policies, especially mixed status households, one potential direction to go moving forward is to use a household level analysis. We have the ability to do that. We are clustering standard errors at the household level at the moment. And two, it is easy to build households of mixed status, both native born or both non-citizen members with the current SIPP data with the household IDs. So that's another interesting direction that we're hoping to explore. In terms of the intersectionality of multiple races in identities, I think a large part of this is sometimes phenotypic. So multiple races going to the same identity. I'm not sure if there's a clear additive or negative effect one way or the other. It's just simply what people see, which is an unfortunate reality, but it's not something that I'm too worried about controlling for in the model. That was the initial response that I had based on what you said. But all the feedback is really appreciated, and it's going to give us some interesting things to think about in future versions of this paper and hopefully future papers spinning off of this topic. So that concludes my comments. So thank you.
Thanks, Richard. That was really interesting. I'd love to see the future work coming out of this.
Do you want to respond to Catherine?
Sure. I'd say thanks again for all the really concrete suggestions, and I also appreciate your suggestion to really bring it back to the literature, because I do kind of start out with this. There are two sides of the debate. There's evidence in both directions, and then I kind of just go off and then don't really loop back. And also your suggestion to do some of the sensitivity analyses conducted in the Branchetti study, which is great, because it's a great idea, because it is actually a very similar study in a lot of ways, except obviously she does focus on immigrant versus native, and I have that third group of the two, I separate out immigrant into two separate groups, but it does feel like that would be a really fruitful direction to go. I had initially been thinking in the direction of including higher income children, and I think that I think it's a great idea to go back to that. I think I ended up moving down to lower income kids specifically, just because there were so many kids, especially in particular states, that really never ever become eligible. They're just kind of like big fat zeros the whole time. And so I just thought this is not really where I'm going to see the most leverage. And so I did try to drill down. And then I felt like I wasn't having enough sample. And so I was like, okay, let's just put it at 250. But it is fairly arbitrary. There's nothing magical about 250, and playing around with that threshold to see if there is, if I'm able to make the case for robust findings, regardless of that threshold, is a great idea. About simulated eligibility, I may have made an error in describing the way that I calculated that variable. It is age, state, month, and so it is just in the month that the kid is, whatever the reporting month is for the reference month, that month is sort of looked at in terms of whether a child of that age and income level is eligible in that state. And so that is It should be pretty granular. Of course, it's much chunkier than individual level eligibility, but it is down to the age, date, month level. So I'll make sure to clarify that in the discussion in the paper. And then your suggestion to push this forward in time, I literally never thought of this. And so the reason why I never thought of it is because the topical module data on immigration, on migration background isn't available after the 2008 SIPP panel. And so I kind of threw up my hands and said, okay, I guess it just ends when it ends. This is really unfortunate, but that's data for you. But actually the idea to move it forward in time, even if I don't have the ability to, say, parcel out that likely undocumented or mixed status group, would be really valuable. So maybe maybe by pushing it forward in time, I could actually do a separate set of analyses in which I just look at immigrant versus native family for the kids, and then I have a longer time series. And so I really like that idea. It seems pretty obvious, like looking at it now, but as I said, I had really kind of focused in on the subpanels for which that topical module was available, rather than thinking about kind of my ideal study world in which I could do some analyses that go into the ACA era, which is, of course, it has been transformational in terms of health policy in the U.S. So these are great, super concrete next steps, and I want to say thank you for reading my paper carefully. It's a topic that's near and dear to my heart, but I haven't had the chance to work on this paper in a while, and I'm actually really enthused to get back to it. So I appreciate your comments, and thanks for taking the time.
Of course, this is a fantastic paper to read. Thank you so much.
All right. Thank you to both the authors and the discussants. So now we'll open it up to Q&A. You can either raise your hand in WebEx and you can get unmuted. We do encourage you to go on camera while asking your question, but you don't have to. Or you can type your questions into the chat and we can cover them there. Okay, so Reese has a question about, sorry, Reese, do you want to just read it, or I'm having trouble getting to the chat?
I can see the question. Yes, that's a very good point of how people answer certain questions. We also see that.
Can you summarize the question for the audience just in case they can't see the chat?
Yes, it's really about cultural differences and how health and anxiety are expressed among the foreign-born citizen and non-citizen population. So it's really about how, if I'm summarizing correctly, how certain groups are going to answer certain questions in a different way that might pattern the results. Short answer, yes, there is. That's something that we anticipate. And especially when looking at the anxiety and some of the self-rated health measures of some of the surprising results of groups you would expect to have higher depression or anxiety, not having that higher result that we would expect. It's something that I don't have an easy way to address. I'm hoping that this access to care measure can kind of cut through that, as that is a simple, have you visited a doctor in the past year? And there's really doesn't lend itself, there's not a ton of variability in how that question is perceived. There's a pretty decent amount of work on how certain groups answer even the self-rated health question in certain ways of what does good mean to someone who has Hispanic who has immigrated to the United States. What do they perceive as good health versus what does someone who is white, who is born in the United States, lived there their whole life, what do they perceive as good? What do they perceive as their reference group of who are they comparing themselves to inherently in their head? So yeah, that's a very good question, and I'm not sure how to address that in the survey question, but it's definitely a disclaimer that we would have to add.
Richard, it looks like you have another question in the text from Cody. who's asking about if you've thought about using more detailed legal status info that's available in the pre-2014 SIP to disaggregate your non-citizen groups.
Yes, that is something we have looked into. In some instances, we worry about the number of cases in each cell, but we do have the data to address that, especially so topical module 2. I forgot to mention that that is the main data that we linked. We just didn't necessarily use the more detailed measures that we had in, I think, 2004 topical module 2 and 2008. Wave 2, the topical module has these detailed immigration history questions, but that's an excellent suggestion, and it's something that we might use going forward in the future iterations of the paper.
Any other questions? Again, you can raise your hand in the, or you can just put something into the chat. So, Richard, I had one question about your graphs, or your, let me see if I can get to the slide. I think you sort of answered it in the discussion, but when I was first looking at these, at your maps, so these aren't cumulative, right? In other words, the policies shown in 2009 are the ones that were just enacted in 2009 and did not, and so they're then not shown in 2010. But those policies are cumulative, right? In the sense that after 2009, they don't go away. They're still in effect, and so they still might be affecting the people who live in that state. Is this just for display purposes, or does your analysis take that into account?
And at the moment, this is for display purposes. That is one of the things that in our next steps of how to best measure those policy measures, and that is something I forgot to mention, so I thank you for bringing that up. Yeah, those policies are still in effect. So just because California had a down year in 2008 for passing policies, I mean, they passed 14 or 15 accommodating policies the year before, and those are still on the books in terms of policy environment. So it's just, we're really trying to figure out how to best measure this policy measure. Are we capturing what we're trying to capture? So like a year over year policy measure of, I mean, I'm gonna keep using California. California in 2008 is a state that passed 5 immigration policies comparable to Washington state, but that's really not reflective of the different policy environments between Washington and California. So again, trying to measure of cumulative measure might be a good idea. There might be some sort of way that we can cluster certain states. So maybe like a silhouette clustering method of finding which states correspond to certain policy environments using all of these years. That's still something we're exploring, but yes, for display purposes, this is not a cumulative thing, but we definitely need to take the cumulative effect of these policy measures, both accommodating and restrictive, into account.
It's also a little bit tough in the sense that, let's say a state passes an extremely accommodating policy, but then they tighten it by 5%. So overall, that's still an accommodating policy, but compared to the way it used to look the year before, it might be counted as restrictive. And so I don't know how you would operationalize that, but like I said, it is still an accommodating policy. It's just not as accommodating, and that's really tough to capture in something like this.
Yeah, I would agree with that. That's something that both me and Courtney are continuing to kind of grapple with and work on. We're really just, how are we? Yeah, it's really how to measure state policy environment, because these graphs on these year-to-year graphs and maps are definitely not the best way to do so. There's a lot of things that go into account, especially when you're doing a longitudinal analysis.
So Paulette, there's a question in the chat for you if you would like to address that.
Hi, Yasmin. Thanks for your question. I'll just summarize. So The question is about children from undocumented families who do manage to enroll in public programs like Medicaid or CHIP. And the questions about whether I've done any research on translators or helpers at the community level who could be helping these families and being trusted voices within their communities. I have not conducted research on this specifically. I would say, so with the passage of the ACA and money available for navigators for states and NGOs to apply for, that may have had a really significant effect. I know that the navigators were supposed to, I think that their main goal was to try to help individuals enroll in the marketplace, but a lot of times when people would show up, they would be eligible for Medicaid, and so they would point them in that direction under, no wrong door kind of policies. And so I do think that the navigators are likely to have had an effect on enrollment. Of course, that's a more recent period than the one of my study. And then in terms of, I think you referred to being trusted voices within the community, I think that what that made me think of most was community health workers or promotores, and that is, I'm not exactly sure of the mechanism, but I know that in California that Medicaid's going to be able to start paying those workers. And so I am really very much looking forward to seeing their role becoming more formalized, because a lot of times right now they are being paid out of shoestring budgets, or sometimes they're just essentially volunteers. And the way that I've heard this group described is kind of like, this is your mom, this is your grandma, these are people in your community, they're not outsiders. And so they really do have a lot of trust in interacting with individuals from disadvantaged groups who may not really want to get involved with government programs or, county offices, that sort of thing. So while my work isn't in that space, I am tracking kind of the changes that are happening more broadly. And I too am really interested in the role of people informally in the community, helping people get access to services. I hope that answers your question.
Right. Are there any more questions? Right. If not, I will again thank both presenters and both discussants. I think it was a really good session. I learned a lot personally, and echoing again what Jason said in the introduction, SIPP is a really rich data set, and we're really happy everyone is using it to sort of produce these great papers. Certainly, if anyone is interested in collaboration with people at the Census Bureau, I think we're very willing to do that. Just reach out and we can put you in touch with the right folks. All right. Thank you, everyone.